Coming to the third part of the fractures of the lower limb, coming to the fractures of the shaft of the tibia. Introduction of that. Most common of all long bone fractures, it is a very subcutaneous bone. It is also known as the shin bone. You can easily palpate it, and the incidence of open fractures is very, very high. The distal 1/3, that is the lower part of the tibia, has quite a deficient blood supply. So the fractures in this area are very notorious. There are a lot of causes of delayed union, means the union of the bone occurs much later. And secondly is that it can also lead to non-union of the fractures. Both the tibia is bounded by two joints, that is the proximally is the knee joint and distally is the ankle joint. Both should be mobile, and we must try to mobilize the patient as soon as possible. Any malunion is not acceptable in these cases. The mechanism of injury mostly is a road traffic accident or a fall. Also, sports injuries are becoming more and more common, and that also contributes a lot to the fractures of tibia. Assault is the least. A few classifications which are important is that Chernet's classification is there, which is associated with the soft tissue injuries. And the other one which is common is the AO-OTA classification, that is Orthopedic Trauma Association, which is divided the fractures into three groups, that is A, B and C. The clinical features of fractured tibia are pain, swelling, deformities, abnormal mobility may be there, crepitus, and if these things are not taken care of, there is high chances of compartment syndrome and injury to the peroneal nerve and the posterior tibial artery. The X-ray investigations which have to be done is the limb X-ray, that is the affected limb, that is right or left, anteroposterior view as well as lateral view. Always you must try to incorporate and do the X-ray imaging of the knee joint as well as the ankle joint, which sometimes you may miss this fractures. So never to miss out and just do a particular region which looks very much obvious, like the fracture of the middle part of the tibia, that is the diaphyseal fracture. As in this case, always the image of the knee also has been incorporated in this X-ray. Here you can see the fractures of the anteroposterior view as well as lateral view. Commonly the fibula also gets fractured along with the tibia. The management of the tibial fractures can be divided again into conservative as well as the surgical management. Coming to conservative management, the indications for conservative line of management are undisplaced or minimally displaced fractures, 1. Low energy trauma, where there is not a road traffic accident or high energy injury. In young adults, you can do. This is done in the form of a long leg cast, that is above the knee, is usually done above the knee, or there is a patellar tendon bearing cast, that is at the level of the patella, a cast is applied, that is circumferentially applied. Coming to the operative management, the indications for operative management are, if there is an open fracture, that is, again we have discussed earlier that there is a compound injury, you cannot do a conservative line of management. The fracture is unstable. If there are segmental fractures, that is the fracture has occurred at two levels and there is a lot of inadequate reduction, also is one of the reasons of operative management. The advantages of the operative management are, it is a definitive form of treatment, there is no loss of position or there is shortening after the treatment, there is no post-operative fracture deformity, and early mobilization of the joint, that is the knee joint as well as the ankle joint, can be freely mobilized. As compared to the cast, there is always kept usually in above knee cast. So after a couple of weeks or month, there is gross stiffness which occurs at the knee or as well as the ankle once it is incorporated. This is a very good example of the operative management done by interlock nailing. This is the X-ray image of a spiral fracture of the diaphyseal tibia. It is treated by the interlock nail with the interlocking bolts are done, and you can see a good union after a couple of weeks time. Similarly, in the same way, fracture of the tibia diaphyseal in the anteroposterior view, treated with the help of plates which are placed laterally as well as anteriorly. The third management is in the form of external fixator. In this image you can see the external fixator with connecting rods and Schanz pins which are being used for the tibia. The third and the last one is the ILIZAROV ring fixator, where there is a severe comminution and segmental fracture of the tibia. It's been treated with the ILIZAROV ring, and there's still good union after removal of the fixator also. There are complications which occur with the fracture tibia, which are commonly the delayed union, the non-union, the malunion. Infections are also very common, especially in compound injuries. Gross shortening can occur. There is sympathetic dystrophy, joint stiffness in the knee as well as ankle, and lastly there can be also fat embolism. The next part of these lower limb injuries are the ankle fractures. Coming to the introduction, the ankle joint is a synovial type of joint. It is a hinge variety. Just like the knee joint, there is flexion extension possible, just like a hinge of a door. As a weight bearing joint, the ankle is exposed to forces that transiently exceed 1.25 times the body weight, with normal gait that may exceed 5.5 times the body weight with vigorous activities. So that is the amount of strain it can cause on the ankle, especially while doing any mobile activities. Structurally, the whole joint is quite strong because there are a lot of ligaments, muscles also, which are providing good support to the ankle joint. The stability of the joint is ensured by the close interlocking of the articular surfaces. There is strong collateral ligaments on the tibial side as well as the fibular side. On either side it gives a good compact thing, and the tendons that cross the joint. They are usually 4 in front and 5 behind. The overlying skin, as just like in tibia, is very thin. The blood supply is very precarious. The tendons crossing the joints are there and they provide no coverage for it. So easily it can be exposed, and compound injuries are very highly common. After severe injuries, the ankle wounds may have problems in healing. An ankle injury can involve, in addition to the bone, the articular surface, that is the surface of the lower end of the tibia fibula, along with that of the upper part of the talus. Ligaments, tendons, nerves and blood vessels which cross it are also very easily prone to these injuries. Percival Pott was the one who described these ankle fractures way back in the 1768. These are still very commonly seen in elderly women. In the mechanism of injury, the twisting injury while walking, running, sports and athletes are very common. Sports injuries like ones seen in basketball, volleyball and soccer are one of the most common injuries in ankle. Fall from height is the second one. The mechanism of injury is very important. There are 2 loads which are always acting on the ankle joint. One is the axial load, that is in the straight line, and rotational load, that is there is some kind of rotational which is seen at the ankle joint. The tibial plafond fractures are caused predominantly by axial loading, whereas malleolar fractures are caused predominantly by rotational loading. The tibial plafond is the level over the ankle joint. This is the joint, and the malleolar fractures are caused by rotation, that is including the medial malleus and the lateral malleus, which are the malleolar region. Coming to the 2 types of injuries seen in the ankle, they are mainly the abduction injury and the adduction injury. Firstly, there is the abduction injury. It's part of this is the tibia, this is the talus and the fibula. In the abduction injury, the talus moves towards the lateral malleus, and there is the medial side, there is a distraction force which is seen on the medial side of the ankle. Similarly, in the adduction injury, the talus now moves towards the medial malleus, and there is distracting forces on the lateral side of the ankle. The next classification which is important in ankle fractures is the Denis-Weber classification, which is based on the location and appearance of the fibular fracture. They are divided into type A, type B and type C. The type A is below the level of the distal tibial fibular syndesmosis, type B is at the level, and type C is above the level of syndesmosis. This is a X-ray picture of the type A, which is below the syndesmosis. Type B is at the level of the syndesmosis, and this is type C, which is above the level of the syndesmosis. The other classification is the LAUGE-HANSEN's classification, which is based on the mechanism of injury, the deforming force acting, and the foot position at the time of injury is considered in this classification. Clinical features of ankle fractures are mainly the pain, the swelling, deformity, abnormal mobility, and crepitus, which is felt on examination. While examining the foot, you must always see for the skin condition. Especially in the ankle, there are the blisters which are clearly seen in these pictures. Tense circumferential swelling and clear fluid filled fracture blisters are present over the lateral ankle over here, and this is on the medial side. So this is not a good sign, and you must not go in for operative management if these blisters are there. You must wait for things to settle down, giving some medications in the form of antibiotics, and then proceed further. Coming to the investigations, in the radiology, we take the X-ray of the ankle in the anteroposterior view and the lateral views. Also, the additional X-ray which is taken for ankle specially is the mortise view. The mortise view is when the leg is rotated approximately internally by 15 degrees. So you can clearly see the fracture of especially which can be missed of the distal fibula as seen in this X-ray. Better imaging which can be further done other than the X-rays are the CT scan, which is standing for computed tomography, which gives a clear-cut configuration of the fracture fragments, or the MRI, that is magnetic resonance imaging, which also gives the soft tissue as well as the bony components, which will help in better management later. Management, as usual, is divided into conservative and surgical form. The aim is very important for ankle management. The normal relationship of the ankle mortise, that is the whole configuration, it has to be restored just like before. Secondly, it's the weight bearing alignment of the ankle which must be at right angles to the longitudinal axis of the leg. And thirdly, the contours of the articular surface must be as smooth as possible. So the articular restoration is very, very important for getting a good functional outcome. Treatment in the form of conservative, the indications are firstly the stable fractures. Second is if there is any medical contraindication to operative surgery. And lastly, if there is severe osteopenia where you can easily give through. So you must give a short leg cast, that is a below knee cast, below the knee, usually given for around 6 weeks time. In the surgical management, the indications for surgery in ankle fractures are either it's for unstable fractures that you cannot get the reduction with closed methods. Secondly, if there is compound or open injuries, and if trimalleolar, that is your tri stands for the medial malleus, the lateral malleus, as well as the posterior malleus, which is specially seen in the lateral X-rays. This is a picture, X-ray picture of fibular plating which has been done for injury along with syndesmotic screw which is placed. So in this image you can see the DCB plate which has been used, that is dynamic compression plate for the fibula, and this is the syndesmotic screw which has been passed from the fibula into the tibia side. The syndesmotic area is very notorious because there is an interosseous ligament which is present in between the tibia and the fibula, which has also to be maintained, and that is why the syndesmotic screw is always put. Of course, there are complications with this ankle fractures. Most commonly always the malunion if not treated properly or inadequately treated. Secondly, because of the vascularity and inadequate treatment, you can also get delayed unions as well as non-unions. Infections are always present if you don't take proper aseptic precautions, or if it's a compound injury and adequate care is not being taken. A wound breakdown is also one of the complications. And lastly, if not treated well, ankle arthritis is also very common. Thank you very much for this session where the fractures of the lower limb we have covered. That is, we have covered the intertrochanteric fractures, the fractures of the neck of femur, the fractures of the tibial shaft, and ankle fractures. Students will see the next session soon.